Hello all, today I will be going over mobile health applications for assignment 1 part 2. The primary audience will encompass all sorts of patients: immediate triage, immediate feedback, diagnosis, treatment. What I mean by that is we were talking about all the vital signs. Those were some more feedback, but this e-health application could go up as hard as someone is having a heart attack or some sort of an emergency. This application would play a good role in it. It'll eliminate all the Q&A between the staff because all the vitals would already have been registered in the system, and hopefully with the physicians or hospitals network as well. The focal issue, there is no, we all know healthcare is changing rapidly. There is no specific method of reimbursement today. How a patient visits, when a patient visits a hospital or a physician's office. Right now, same thing issue would be here. If there are diagnoses being done by physicians, how does in applications and e-health apps, what sort of reimbursement structure would take place? How will healthcare track this? This would be quite a immeasurable item, which would really need to be sorted out from a compliance standpoint. They will definitely be far from the traditional investments in healthcare system where you just simply purchase a software and track it. These are individual inventors who are providing these apps, so there will be some sort of a collaboration that would have to be taking place. The scenario logics is personal health responsibility regulations, labor mix, and quality of indicator of reimbursement, which I sort of went over in the past slide. We need to make sure that these records are kept safe, and even though it's a patient's responsibility, it has to be harped on that this is a very secure network where the data of patients is being transmitted to hospitals or physicians. Regulations have to have a good pulse on it. There could be a labor shift fix because there could be a learning curve for people. People are used to seeing patients, but now they have to interact with the software, which is downloading the data of patients, and they have to make sure that the information that they're reading is indeed accurate, and they're synchronizing their notes and such back and forth. So there could be a more technological sort of training involved. And then again, the reimbursement part. What's a good quality service versus a bad, and how well do they get reimbursed? Does the insurance company, do they have the right codes and such to track this interaction between the two? The scenario plans in all the 4 scenarios would be the personal health responsibility under eHealth would encompass patients having proactive treatments versus waiting for an illness to occur. So this will make the accountability model quite well, because things will become when there is an interaction between a patient and a provider. A lot of the legwork has already been done, that there's an actual issue here versus trial and error. Again, the HIPAA compliance, this would be an interesting one, because no longer is just they're focusing on all the medical records of a physician's office or a hospital. They actually have to look at all the vendor relationships which have these applications, and what sort of process do they have in place to ensure they're secured and there's no breach of data. Then the third one is managing the pool with an unknown labor pool. What I mean is momentarily there's a lot of physicians who are not necessarily attuned with this model, but by them having appropriate e-health softwares or their preferred e-health applications in their offices would would make them would 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 encourage their patients to download such apps, and they would hire people who have either experience in this or are have some similar background that they could give them that they would prefer. The last one is paying the bills. The same thing. This is going to be an ever evolving change because people have to decide how are these mobile health applications going to be reimbursed. If indeed it is a diagnosis, is this a pay per play model, meaning if a patient is using it, every time they use it they pay for it, or is this a subscription model where it's just like any other time you would make an appointment with the physician. Conclusion is after reviewing all the scenarios, it's we have to recognize that e-health applications is here to stay. If anything, it's going to get larger. Um, the Based on the e-health advancement and government approval, this will really have a momentum. And as I said in my previous presentation, I believe that e-health sits to the trough of delusionment because there's a lot of kinks being worked out. The companies are conducting studies, and they are creating actual plan of care for both practical purposes and making them step by step further engagement of this specific type. We've seen technology and we've seen the communication grow: Twitter, Facebook, Instagram, Snapchat. So this sort of communication is a matter of time in this arena as well. I won't go into all the rest of the slides for the respect of time, but I will attach it to my presentation. Thank you.